forward to this session. This is my favorite session from 2019. These are also two of my favorite people. I'll start with Dr. George Ibrahim in no particular order. He is now on our scientific advisory board. He's the pediatric neurosurgeon at the Hospital for Sick Children. He never says no to us, which is really awesome. Similarly, Dr. Abel never says no. He was on our scientific advisory board and now is on our board of directors. And he is the chief of pediatric neurosurgery. He's now the chief, right, of pediatric neurosurgery at UPMC Children's Hospital of Pittsburgh. They both have really long resumes that I'm not going to go through right now. They gave a talk in 2019 on VNS, RNS, DBS. It's got almost 6,000 views on our YouTube channel. It's really, really good. And they're going to give you an update on what's new in neuromodulation.
5,000 of those views are me hitting reload on it.
And the other 1,000 are me.
So this is the second time we have done this. We started working on this about an hour ago at California Pizza Kitchen. And anyway, it's an honor to speak with you today, especially with my colleague, friend, and former mentor, George Ibrahim, who's the Abe Bresver Chair in Functional Neurosurgery at the Hospital for Sick Children. But he's a good friend, and this is a topic we're both very passionate about, and so we're excited to speak with you about this today. These are our disclosures. You'll notice that George's disclosures it's a longer list than mine, but it's important for us to mention those. Please don't try to read or memorize any of our slides. Our goal is to get through this quickly and then to leave a lot of time for questions at the end of this. So we're going to start by talking about what neuromodulation is. We're going to talk about the different forms of neuromodulation that are used in epilepsy. We're going to talk about combining different neuromodulation strategies, combining neuromodulation and resection strategies, and then we're going to talk very briefly about how you make the right decision for neuromodulation in your child. And I'll start by saying, when is it time to consider epilepsy surgery or specifically neuromodulation? And this is the place to start because this is a recent referral guideline from the International League Against Epilepsy. This is an expert consensus statement. And what this says is that referral for a surgical evaluation, whether that be for resection or for neuromodulation, should occur when a child or an adult, an individual with epilepsy, has drug-resistant epilepsy. So that means they're on 2 appropriate seizure medicines, but they are still having seizures. And so we want to start there, because you may wonder who's a candidate, and these are who the candidates are. We're going to start by talking about VNS, and I'll turn it over to Dr. Ibrahim.
Well, good afternoon, everybody. Maybe we could do this. What do you think?
This is better.
Much better, much better. So I'll talk about VNS, and just to introduce myself, George Ibrahim from Toronto. So it's wonderful to be south of the border. And I do want to say that Dr. Abel is a very good friend, and it's the other way around. I've learned a lot from him. And that's one of the wonderful things about our community. We're all learning from each other. The pediatric neurosurgery community is filled with people who are really, really dedicated to taking care of children with epilepsy, and it's an honor to be a part of this amazing, amazing community. Vagus nerve stimulation. This is an area of research that I'm actually particularly interested in, and Dr. Abel and I are collaborating on various projects related to vagus nerve stimulation. Together, we've actually put together the largest registry of vagus nerve stimulation procedures in pediatrics in the world. And in the next few years, we're going to be putting out several analyses to try and understand which child benefits the most from vagus nerve stimulation. When should you do it? When should you not do it? So there's a lot of excitement about this relatively old technology to look forward to in the next few years based on our collaborations that we've started with about 13 other centers across North America. The way that vagus nerve stimulation works, if you're not familiar with it, this is the oldest neuromodulation technology, is that it's a form of extracranial stimulation. So as many of you know, there's a battery that's implanted under the skin in the chest. The battery is connected to a wire that goes to the nerve in the neck, the vagus nerve, and it sends impulses to the vagus nerve that go up the brain to this network that we're still trying to identify and characterize. And then that network, when it's stimulated, leads to a reduction in seizures in some children in whom we implant. The surgery, it's not a brain surgery, it's a neck surgery, though the impulses travel up this vagus nerve to the brain and change brain circuitry to reduce seizures. And the advantage of vagus nerve stimulation is that it has very low complication rates. Not zero, and we've certainly, if you do enough of these, there certainly are complications that can arise, but in general, they're low complications, and the most relevant risk is a risk of infection.
It's important to note that if you take all of the studies that have been completed on vagus nerve stimulation and you look at them like we have plotted here, that the outcomes vary widely depending on the study that you're looking at. And that probably reflects that these studies are including different types of patients with patients that have different types of epilepsies that are highly varied. But when we take a look at all of these studies together and we systematically, or we meta-analyze them, meaning we take all the data, we clump the data together, and then we do a single analysis. In general, we can say that about half of patients who have VNS will have their seizure frequency cut in half. And so in general, that's how I counsel patients that are going to have vagus nerve stimulation. And so one of the things I'll say to patients before they have vagus nerve stimulation, when we're talking about risks, is I'll say, well, one of the biggest risks is that we won't have a noticeable effect of this surgery. And the chances of not having a noticeable effect is about 30%. However, there is an effect potentially on what's called sudden unexpected death in epilepsy. And so these are two papers, one by Sandy Lamb and her team at Lurie Children's, and another by Philippe Rivlin and his team in Switzerland, that have actually shown that with vagus nerve stimulation, the risk of SUDEP, sudden unexpected death in epilepsy, actually decreases over time. So this may be one of the potential benefits of vagus nerve stimulation. And so one thing I wanted to mention is often we're considering vagus nerve stimulation for individuals with epilepsy who have several different types of seizures, but specifically have what are called drop seizures, which are atonic seizures or tonic seizures that result in drops. These drop seizures are really important to consider because they can lead to injuries, trips to the emergency room, and can be dangerous. And so when we talk about vagus nerve stimulation, even though this is a talk about neuromodulation, I think this is also an important opportunity to talk about corpus callosotomy, because corpus callosotomy, when we're thinking about drop seizures, is a far more effective treatment strategy compared to vagus nerve stimulation. And so if we do, one of the things we do in our lab is what's called decision modeling. And decision modeling is a way of simulating a clinical trial when you're dealing with a problem that you can't do a clinical trial on because maybe you're dealing with a rare disease like epilepsy. And so what we show is that if you're looking at the odds of a treatment being effective at reducing drop seizures in half by 50%, you have an 80% chance of achieving that with corpus callosotomy compared to only a 50% chance with vagus nerve stimulation. And so it's important to bring this up because even though vagus nerve stimulation is very attractive because it's not a brain surgery, corpus callosotomy can be very effective, more effective, and we now have ways of doing corpus callosotomy in a less invasive fashion. So it used to be, corpus callosotomy has been around since, I think, the 1940s when I think Van Wagenen did the first one. for a patient with dropped seizures. But it used to be that we had to do this big craniotomy through a really big incision, and then we would go in and disconnect the corpus callosum. Now we can actually just place these small laser fibers into the corpus callosum and actually sever the corpus callosum with a laser. And our recent systematic review shows that this seems to be just as effective as an open corpus callosotomy through a large craniotomy.
Wonderful. So, VNS is by far the procedure that's most commonly done, that has the most experience, where there's thousands and thousands of children that have been treated. But there are other procedures that we do that are quite relevant for children with epilepsy. Maybe by show of hands, how many folks are familiar with VNS? By show of hands. Perfect. Yeah, so-so counts. So-so counts. Familiar or so-so. How about deep brain stimulation? Okay. And how about responsive neurostimulation? Okay. So, for those who haven't seen, for those who are online, the numbers kind of decrease when you go from VNS to DBS, and RNS are roughly tied. I'll talk about a bit about deep brain stimulation. This is a technology that has been adopted recently into our armamentarium. It's been around for decades and decades and decades, largely for movement disorders in adults. So deep brain stimulation was pioneered primarily for Parkinson's disease, for a movement disorder in adults, where electrodes are put into the brain, and I think we have a photo here, through two small openings in the skull. And these electrodes, historically for Parkinson's disease, were implanted in the part of the brain that initiates movement. And one of the issues with Parkinson's disease is tremor and slowness of walking in older adults, as some of you may know. And when you stimulate the parts of the brain that control movement in Parkinson's disease, you can actually make the tremor go away. And this is what it looks like. It's a procedure that is usually done in adults while they're awake, but in children, it's always while they're asleep. Whether you're a 2-year-old or 17-year-old, it's always asleep at our hospital. We don't do any pediatric deep brain stimulation awake. And the electrodes are tunneled under the skin to a battery that sits in the chest, like vagus nerve stimulation, and essentially it's used as a treatment for epilepsy. So in the Parkinson's scenario, it's put in the part of the brain that initiates movement, which makes a lot of sense. For epilepsy, it's implanted in the part of the brain to which the seizures propagate, and that's the thalamus. So the thalamus is, the grand central station of the brain, where all the signals from the brain, from the right side to the left side, going from the top to the bottom, pass through the thalamus, including epileptic activity. So the goal of implanting the thalamus with these electrodes is to reduce or modulate the flow of electricity through this hub and reduce the seizure burden. And there's a few different targets that were used. The two main targets are the center of the thalamus, the centromedian thalamus, or the front of the thalamus, which is the anterior nucleus of the thalamus. There's one large trial that's been performed for the center of the thalamus, the centromedian nucleus, and one large trial that's been performed for the front of the thalamus, the anterior nucleus. Both of them showed that when you deliver electricity to both of these parts of the thalamus, you can reduce seizure burden for different types of epilepsies. The anterior nucleus is largely partial, or what used to be called partial seizures, and the best evidence for the center of the thalamus is for LGS, Lennox-Gastaut. All of these studies are in kids. And we had a few slides on, all these studies are in adults, but we had a slide on pediatrics. There's data that's come out over the last few years from our group and others about treating children with deep brain stimulation. This is our trial that we just published, and this is the first clinical trial in pediatrics. And the topic of today's session is what's new? Well, this came out about 2 months ago. So this is the first clinical trial of using deep brain stimulation in pediatrics, in addition to vagus nerve stimulation. And in this trial, we recruited several children that had VNS. The VNS could have been effective, but it didn't work completely, or it didn't work to the satisfaction of the families. So we added deep brain stimulation on top of the VNS. And this was a randomized trial, but it was randomized with patient preference. So some families wanted to have the DBS, and some families didn't want to have the DBS. They wanted to continue with the vagus nerve stimulation. And we followed both arms for over a year. After a year, we then looked at the seizure outcomes between the families that were either randomized or chose to have an extra year of VNS, and the families that chose to have deep brain stimulation added to the VNS device. And we found that when you have the addition of DBS to the VNS, you had significantly less seizures after a year than the VNS alone. And this is actually really important, because in pediatrics, the mantra, a lot of people still say, give it time. Give it a year, or 2 years, or 5 years. Some people say up to 10 years for the VNS to work. And what we've shown, and what we strongly believe, is that after a reasonable amount of time, for us that was 1 year, for others it may be a little bit longer, it should be that clinicians look for other options. Something like deep brain stimulation, which can improve seizure outcomes on top of VNS if it's not effective.
So now I'm going to spend the last third of our talk talking about responsive neurostimulation. And what RNS is it's a device that we actually implant in the skull through a small craniotomy, meaning an opening in the bone, that's connected to 2 electrodes. And those electrodes are able to sense when seizures are starting, and then deliver a therapeutic stimulation in response to the seizure starting. And so this is an example of what the device can look like. You can see the device here is implanted into a small window in the skull. And then you can either use these depth electrodes that can be implanted directly into a seizure focus, or you can use these cortical strip electrodes that are implanted on top of a seizure focus. And this depends on whether it's a deep seizure focus or something that's on the surface of the brain. And actually, let me go over a little bit about the impetus, or why we use responsive neurostimulation. One of the most effective strategies we have in epilepsy surgery is to remove the part of the brain that's causing seizures. But we can't always do that. And so sometimes seizures will be coming from the part of the brain, just the part of the brain that's affecting vision. And so maybe it doesn't make sense to do, or wouldn't the risk benefit of doing a hemispherotomy would not make sense, but it would make sense to remove that part of the brain. But you don't want to remove that part of the brain because it serves vision or language or motor function. RNS is a strategy where we can implant electrodes into that part of the brain, sense when seizures are occurring, and then stimulate in response to the seizures to prevent them from becoming larger. And we know from doing this in many patients that it can be effective. The procedure is similar to DBS when we're placing electrodes deep into the brain. Some RNS electrodes are placed right on the cortical surface, and so if I'm placing one of these strip electrodes on the cortical surface, I put it through that same window that we used to place the battery. And like I said, the RNS pulse generator is implanted in the skull. And on average, you need a revision surgery every 8 to 10 years to have the battery replaced. And that's in contrast to VNS, where it's really every 3 to 5 years where you need a battery change. And in DBS, we actually have rechargeable batteries that can last up to 15 years sometimes. There are different places where we put the electrodes. For example, there's something called bitemporal epilepsy, where epilepsy starts from both the left and the right mesial temporal lobe, meaning the middle part of the temporal lobe. we know that we can't remove both of the mesial temporal lobes, because if we were to do that, you wouldn't be able to form new memories. And so we do bihippocampal RNS for bitemporal epilepsy. For multifocal epilepsy, meaning epilepsy that starts in maybe separate and distant parts of the brain, we can implant electrodes into these parts of the brain. And we can also try to target larger areas of the brain with what's called regional stimulation. And the reason why there's a lot of excitement about RNS is that this 9-year prospective study showed that RNS can really be effective for reducing seizures for a subset of patients. And what's also exciting about RNS is that we can use it not only for treating seizures, but also for detecting seizures. And so this is a paper that described in patients that were thought to have bitemporal epilepsy, that when we record from both temporal lobes with RNS over a period of time, we actually get a better idea of which temporal lobe is contributing more to the epilepsy. And then if we find that 90% of the seizures are coming from one side, you can actually remove the RNS electrodes and remove that temporal lobe, resulting in much better seizure control. There's been a trend towards using RNS similar to using DBS. And what we mean by this is, rather than placing the RNS electrode into the cortex, like language cortex or visual cortex or motor cortex, we're actually targeting the thalamus, so the brain's grand central station, and using RNS similar to DBS. And so, for example, putting RNS electrodes into the center part of the thalamus or the anterior part of the thalamus. This is an example of what that looks like. You can see the pulse generator implanted in the skull here, and 2 electrodes that are implanted into the centromedian nucleus of the thalamus. This strategy is beginning to be used more and more for young adults and children with primary generalized epilepsies. But this is a new technique, and we're still trying to sort out how effective this really is, though we seem to have good results so far. Dr. Ibrahim talked about this a little bit before, but there's an emerging literature showing that sometimes when you have a combination of different neuromodulation devices, in this instance VNS and RNS, or VNS and DBS, there seems to be more of an effect than if you only have one. And so a lot of times families will ask, well, I already have VNS, can I have DBS or RNS? And the answer is yes. We now have more and more experience using these devices in combination with each other. So if one device doesn't work, that doesn't mean you shouldn't try something different. Another combination therapy that has been used is combining resection of the brain with RNS. And so where this might be useful is, for example, sometimes we find a seizure focus in the frontal lobe, but part of that seizure focus, and the seizure focus is large, but part of the seizure focus involves motor cortex. One way that RNS is now being used is that you remove the section of the frontal lobe, for example, that is safe to remove, but for that part that's not safe to remove, that involves motor cortex, you can put electrodes on it rather than removing it. And this is a paper that described doing that, but more and more groups are beginning to use that as a potential therapeutic strategy. So finally, we want to talk a little bit about how we make decisions. And this really is to prompt some discussion that will begin after we wrap this up in the next 2 slides. There are so many options. How do we make decisions on what's right? We have limited evidence for some of these newer technologies, and actually even for VNS, where it's been around so long that it's actually difficult to fund clinical trials because it's almost like the field has lost excitement for it. And these clinical trials are so expensive and so difficult to do. So I think my suggestion and what I do with my patients, and Dr. Ibrahim does with his, is you sit down and you discuss the pros and cons of each approach. And you also discuss what are you and your family comfortable with. For example, one of my first centromedian RNS patients was the child of an otolaryngologist, so a head and neck surgeon who just said, you know what, I've seen enough complications of VNS in my head and neck practice that I would never want that for my child. Do you have any other options? And that was actually one of the first patients we did a centromedian RNS for. And so that decision wasn't necessarily motivated by medical evidence, but it was motivated by what the family was comfortable with. And because the mom was a head and neck surgeon, she just didn't want her child to have a neck surgery. And that child ended up doing really well. But there can be other factors that go into a decision also. And so it's just important to discuss the pros and the cons. George.
And the last comment, I think this is the last slide that we have, because we do want to leave this open for discussion. The last comment that I wanted to add is there are options. Right? There are lots and lots of options, and we are just beginning to scratch the surface of what neurotechnologies can potentially offer to families with epilepsy. We know about VNS, and we have lots of experience with it over many years. We are gaining additional experience with DBS over the last decade or so, same with RNS, and we're just now beginning to understand what happens when we combine them in different ways. In the next few years, I am confident we're going to have a better sense of which child is likely to benefit from which technology, so we can tailor and personalize neurotechnologies to different patients and families. But I'm also confident we're going to have smarter devices. We're going to have more intelligent implants that we can use and leverage to understand seizures better and to treat them more effectively for families. So, you know, what's new in neuromodulation? I don't know. I think the future in this space is enormous, And I'm not talking about Neuralink or Elon Musk or anything like that. I'm talking about really tangible changes that I'm seeing in this field, in the development of technologies, and really they're to treat epilepsy, but also to help us understand how epilepsy impacts the brain and develop treatments that improve quality of life. So I'll leave it at that there's different strategies that could be considered. We strongly believe, I think Dr. Abel and I are very much proponents of early consideration of these therapies. Not just because they can reduce the burden of seizures, but they also reduce potentially conditions such as SUDEP, which is extremely dangerous, and improve quality of life. And the best strategy is not always known. It should be personalized, and we will have better ways to personalize it in the next few years. So maybe I'll leave it at that, and we have lots of time, hopefully, to open it up for discussion and hear from you.
Thank you. Oh. It's just for the camera. Oh. Oh, it's just for the camera. Got it. Thank you. That was great. Thank you so much. I think we have at least 2 RNS post-hemispherectomy families in the room. Could you talk a little bit about using RNS after failed anatomical hemispherectomy when you only have cortex on the other side?
Yeah. So actually last time we gave this talk, I had some slides on this, but I think we're still trying to sort out what the outcomes are for RNS after hemispherectomy. And so what this is for children with hemimegalencephaly, there's often a cortical dysplasia contralateral to the side of the hemispherectomy. And that's probably why, even after hemispherectomy, the odds of seizure freedom after hemispherectomy for hemimegalencephaly is about 50 to 60%. And so what some teams have begun to do is to use RNS as a way of treating the seizures that are coming from the more healthy side that was not removed or disconnected, And what that involves is placing electrodes either on the surface of the brain, or some groups have used a combination of thalamic and cortical stimulation to stimulate cortical dysplasias in the contralateral hemisphere, with the idea of using this as a treatment for seizures after hemispherectomy from the more healthy hemisphere. This is, I know of, I think there may be 5. There are probably about 5 children that have had this done in the United States. I think I have heard that I've heard some great outcomes, and I think there are some where we're still trying to sort out how it's working. So if you have experience with this in the audience, I would love to hear more about it. But you don't have to speak publicly in front of everybody.
Do you want to? Yeah. Go ahead. Can I put you on the spot?
Oh gosh, okay. My daughter is 11 at the end of this month. She had a anatomical hemispherectomy at 11 months old. Continued to seize afterwards. We had 3 laser ablations in 2022, I believe. Still continued to seize after that. And so we had the RNS device placed in February of this year. We actually put it on her skull of hers. So she had a left anatomical. So we put the RNS on the left side and drove the probes in through there. So they're placed on her right side. So the RNS device, y'all turn it like the electrostimulation up. So she's at a 1.0 right now with no seizure control. But they tell you prepare for 18 months before you start seeing some changes. So we're in it for the long run, but she does have the device placed, and we're just kind of waiting to see what happens from there.
Thanks for sharing.
Yeah.
I think part of the reason, and you made really good points, part of the reason why it'll take some time to know is because it does take some time to ramp up the stimulation, not just after hemispherectomy, but whenever you're doing any of these types of neuromodulation therapies. That was brave. Thank you.
Open book.
I'll maybe say one comment too about access to these devices. I'm Canadian, so it's nice to be here. RNS is not approved in Canada. We actually just did the first RNS procedure in Toronto last year, I believe, and we've since done a total of 3. So in the entire country of Canada, there have been 3 RNS implants that have been done. And you think, gosh, this is unfortunate, and it is. But I would also say there is a lot of inaccess to these devices within the U.S. And some of that is geographic. Maybe more rural communities have less access than urban communities. But I would say that some of that inability to access these devices comes from a lack of knowledge that they exist and that they could potentially be helpful. So this is, I think, a tremendous opportunity to educate providers, to educate individuals with epilepsy that these devices are tremendous. We have access to them, and they can potentially be very, very helpful. Some insurance providers in the US, I know, are reluctant to cover these devices for children because deep brain stimulation, for instance, is only FDA on-label approved for technically only one target in the thalamus, the anterior nucleus, and only in individuals 18 and above. Now, the vast majority of comprehensive epilepsy centers in the US and Canada are offering these devices to children, but I think there's an enormous opportunity to advocate and educate everybody, from healthcare providers to policymakers to insurance companies, because access to these devices is really something that needs to be prioritized.
There's much more to say about that, but I shouldn't talk about insurance companies. Any other questions?
Hi, yes. So my son, we're just starting to explore surgery for his drug-resistant epilepsy. So we haven't gotten official recommendations yet, but the different epileptologists we've spoken to at our home hospital, which is Boston Children's here, some of the epileptologists have said like, oh, he absolutely wouldn't be a candidate for any of these devices. And some have said, oh, maybe we should consider one of these. And so I was just curious from your perspective, what are the cases generally in which someone would absolutely not be a candidate for any of these devices and why?
This is tough to answer without knowing more specifics. One thing I would say though is that we have 8 epileptologists at our center, and we get into this room together and we have these sometimes ferocious debates about what's best for which individual. And because we talk about treating the epilepsies. And what that means is that the epilepsies are so varied, and everyone's epilepsy is different. And then I have certain treatments that just wouldn't work for certain families. For example, when I do deep brain stimulation, I always use rechargeable batteries. But then I've learned that unless the parents are really responsible, you should not use rechargeable batteries because they'll forget to recharge them. And so a lot of different things go into this decision. And one thing, it's tough to do this in certain parts of the country, but I think it can be helpful. If you're at a center that has multiple epileptologists, you can get different opinions. If you're in a region where there are a couple different centers, you can get a few different opinions. And I think that can be helpful to provide you perspective, and also for the providers to hear what opinions you heard from other centers.
So I agree with Taylor, of course. I usually do.
You don't have to.
But I usually do. The one comment that I wanted to make, and I don't know the particulars, of course, but and I think if it wasn't clear in the talk, all of these devices are wonderful, and there's a lot of advances that are being made. None of these devices are better than a resective epilepsy surgery. If there is a child who has localization-related epilepsy with clear focal onset and it's safe to do a resective procedure, that is the single best treatment option for that child. The goal of all of these devices is to reduce seizure frequency, but it's not seizure freedom. There are about somewhere from 5 to 10% of children with these devices will be seizure-free, but 90 to 95% of children will not. So it's a very small proportion that are actually seizure-free for this. So in some children, in a roundabout way I'm trying to say, in some children there are better options. In many children there are better options than these devices. And some children have contraindications where it's unsafe to do these procedures. For instance, if a child has radiation to the neck or trauma to the neck for one reason or another, it may not be safe to put a stimulator in the neck. If there's vascular malformations in the brain, it may not be safe to put an electrode through the brain. But by and large, those are fairly exceptional circumstances. The vast majority of children, I think, could have an option available to them. The evidence to choose which technology is best for which child and which of the epilepsies responds best to which device is lacking, to be very honest. We're building those bodies of evidence. You know, we have a large multi-site collaboration for VNS. There's other multi-site collaborations for RNS and DBS. So the evidence is coming. But you know, there's a saying, you know, you could do a lot with a little bit of knowledge. So even without a lot of knowledge to inform us, there are still many, many options that could be relevant.
Thank you. I'm curious about in what circumstances you would recommend DBS on the cerebellum?
I'm going to let George start.
So none is the short answer.
I was going to
But-
say for dystonia, maybe.
So the cerebellum is actually the first target that was ever used for epilepsy. And it's very interesting circuitry behind it, because the cerebellum is a very, very robust inhibitory organ. There's all of these enormous inhibitory projections from the cerebellum to the brain. So the thought was, gosh, maybe if we stimulated these huge inhibitory outputs, maybe we'd inhibit seizures. And that was the first deep brain stimulation target for epilepsy. The benefit of cerebellar stimulation was on the order of 20% or less. So it was largely abandoned because it doesn't work. Interestingly, there's actually a few papers that have come out in the last year or so looking at connectomics, studying how the brain is wired, that seem to suggest that there's certain forms of epilepsy, of drug-resistant epilepsy, that may relate more to cerebellar circuitry than others. So I potentially foresee some interest in cerebellar stimulation in the future based on those studies, but as it currently stands, that's an outdated technology, but as with most things, they're rediscovered at some point in time.
Thank you.
You may hear more about cerebellar stimulation because people are starting to think about it for acquired dystonias, for children with cerebral palsy. Anyway, I agree with everything George said, and I'm glad he's here because I couldn't answer the question that well.
Hey there, I heard you guys in 2019, and I think at that time I asked you if it was possible to remove a VNS. My daughter's had a hemispherectomy and is doing incredibly well, but she has the device implanted. And so I'm curious, have you guys removed any? How common is it? I've heard it's dangerous, I've heard it's safe. I just am curious what your thoughts are.
This is a great question. So I think the bottom line is that removing a VNS is a lot tougher than putting it in. And revising the VNS, meaning removing a vagus nerve stimulator from the nerve with all the scar tissue there, and then putting a vagus nerve stimulator higher up on the nerve, is even more difficult than that. And so the way we do this at our center is we talk very carefully with patients about it before we do it, and just make sure they understand this is not like the last surgery you had. This is a much bigger surgery, and we want, where usually you're in the hospital overnight, and your neck can be sore and swollen for a while, and it can affect your swallowing for a period of time. You have to eat soft foods for a while. It's a bigger surgery, and then we do it in collaboration with our head and neck team, so that we actually have a head and neck surgeon that helps with the surgery in the neck, just so it's safer. And they also do a scope before, so we can make sure that all the nerves that are involved in the surgery are functioning at baseline before and also after we do the surgery. And so it's a much more involved process. And so generally the way I counsel families is, unless there's a really good reason to do it, we generally would not recommend doing it. But if there is a good reason to do it, we do it with a team where we're doing it as safe as possible. For example, I had a patient who their parents would just notice that they were always kind of picking at things, and they actually picked their leads through their skin. I didn't use here anybody. not through the skin, but they were kind of moving them underneath the skin. And it was just clear that leaving them there was not safe. So it was safer to do the surgery to remove it. Sorry, I didn't mean to. So sorry. I'm sorry. All right, I'm going to hand the microphone to George now. But I hope that was helpful.
I'm going to take the mic from Taylor. I fully agree with everything Dr. Abel said. All of these devices, the beauty of them is that they're reversible, right? Including removable. Anytime you turn on the stimulation and you have side effects, and we do see some side effects of deep brain stimulation related to the electricity, where the electricity is being delivered. If you're stimulating too much of a volume, then you get usually it's paresthesias, sensory changes with centromedian nucleus, with anterior nucleus. Sometimes it's been reported mostly in adults. I've not seen this, but in adults, memory changes, because that's a memory circuit. But it's, at least in theory, fully reversible, which is the beauty of it. I have removed VNS devices before. I'm sure Dr. Abel has as well, and I fully agree with everything that he said. The main disadvantage of leaving it in during a child's lifetime is MRI scans. That you can't have body MRI scans with a VNS device in the chest, but if you need to have an MRI done and it's necessary, then yes, it can be removed. But if it's not bothersome, then I think it's reasonable to leave it in.
Can I ask a follow-up to that? So isn't there some types of MRIs that can be done with this?
You can still have a brain
Brain.
MRI, and you can still have like a neck MRI as long as the VNS is at a certain level in a certain location in the neck. But MRI technologists and MRI teams are generally pretty strict because of the safety implications of having an MRI with a wire there. And so actually the reason why we started doing our removals with a special team is I had one patient who really needed an MRI. And so I went to remove their VNS, this was years ago, and I got all of it out except for one last little bit. But because that one last little bit was there, they couldn't have their MRI. And so we went back in with a neck surgeon, we took it out, and it worked so well doing that that's the way we do all of it now. And so it can be done, but it can be difficult and certainly more stressful and challenging than the surgery of putting it in.
Hi, my son Wally has polymicrogyria in both frontal lobes, general seizures that have happened, and wonderful support here at Boston Children's because we're local. But we are starting to evaluate this. He's only 10, and I know there's not a lot of data out there. How much, I guess you could say, weight or consideration are we that puberty's around the corner? And I'm really concerned that we're going to do something and then it's all going to change. But can you give me some idea of like how you guys approach that?
Yeah, absolutely. So I will say, Dr. Abel has published the world's largest series on VNS in young children. I believe younger than 6. VNS is FDA approved for children 4 and older, but we have implanted it in children 1 or less. The youngest child I've implanted DBS for is 2 years of age, though that was under exceptional circumstances. It really comes down to the risks versus the benefits. And I know that may not be a satisfying answer. Disclaimer. I have to say we've been implanting DBS long enough now that we have followed some children through puberty, and we have a very large DBS program. So we followed several children through this. I've not seen that be an issue. The main issue with implanting DBS at very young ages, and I would say below the age of 5, is that you get enlargement of the skull and the brain is still growing. So you get migration of the electrodes of the DBS out of the target. That's, I think, the main consideration. And it's generally accepted that the younger you implant, the higher the risks. The skin is smaller, is thinner, the skeleton is still developing, so the risks are a bit higher in terms of the durability of the device. I've not encountered any issues related to puberty per se, and if the seizures are severe enough, that would not be something that would hold me back from recommending the device, but it's risks versus benefits.
I think it can also be helpful to, if I had this question in my clinic, the next thing I would do is text our epileptologist and say, is this an epilepsy that's going to change during puberty? And sometimes the answer is really straightforward. They'll say like, no way. Or they'll say, yeah, it might get better or it might change. Maybe we should see how it goes. But so there could be some important input from the epileptologist. But I agree with everything George said about the risks and benefits of, especially at age 10.
Well, I feel like we had 3 years seizure-free because we went on a CBD product, and we lost it. And I feel like we just flopped that holy grail. Yeah. And this is just a tough thing.
The other thing thing that's important to remember is I feel like in kids, there's just no waiting for a clinical trial. I mean, we're not going to get a clinical trial. Nobody's going to fund it. They didn't do it for VNS. It's just not really cost effective for the device companies to do that. And so we just have to sometimes work with the best evidence we have, realize we're dealing with really rare conditions, and weigh the pros and cons really carefully rather than wait for perfect evidence.
One last question.
Quick question. My daughter actually was 3 when she got her VNS, 3 and 1 month, so she was very young. Just had her hemispherectomy in January at 5. I kept her VNS in. By keeping it in, my question is with pacemakers, if the battery dies, that can cause issues with MRIs and things like that. Is it the same concept with VNS because it's the same type of equipment? Is that something you should be interchanging every so many years?
So I think an important question is, I would talk to your team about this, but an important question is your child still using their VNS?
Yes.
And so if it's still, so I think, so if the VNS is in, and there's some specific questions that we don't necessarily need to get into, but for people where the VNS no longer seems to be contributing to seizure control, it's better to kind of slowly turn it off and wean it over the course of several weeks than to just let it run out suddenly, because sometimes that can cause seizures to get worse. I'm not aware of any MRI safety issues with having it run out of batteries. Are you, George?
No, only if the wire disconnects. That's the main thing. You can't have an open circuit. That's, I think you heard that.
Yeah.
But, and you can assess whether there's an open circuit by checking the lead impedance, which is what they do every time you go to the neurologist.
The one